We have a big turnout, and I don't know that we anticipated all of you showing up, but we're happy to have you. I'm Muntu Davis. I'm the director of the department here and also your Alameda County Health Officer. And I'd like to get an idea of who's in the room. So staff, I recognize. Hi, staff. Hopefully you got your lunches. All right, so do we have folks who work in government, city government? Great. County government? Great. Anybody who live in Alameda County? Whoa, all right, so this is about you. All right, anybody who works for a community-based organization? All right, good, good, good. Anybody that works for a foundation offering up some money? Oh yeah, I said that last part. The hands went, not today, not this room. All right, anybody specifically working in healthcare? Good, 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 good. All right, who am I missing? Who am I missing? Students. School districts, yes, school districts. Few, okay. Social services? Good. Mental health, behavioral health? Awesome, awesome. Any community members? Just community. All right, all right, all right. Did I miss anybody? Yes.
How about Centers for Independent Living?
Center for Independent Living. Yeah. Very cool. All right, all right. Well, fortunately, all of you have a role to play in impacting the data that's going to be shown today. Now, some of you may not know or may have heard our vision. Our vision in Alameda County is that everyone in Alameda County, no matter who you are, and that's one thing that we hadn't always said, who you are, where you live, how much money you make, or the color of your skin, has the same opportunities to live a healthy, fulfilling, and productive life. Okay? That's our vision. It's a big vision. And each of you in this room has a role to play from where you sit, both in terms of either your employment, where you work, or as a community member. Okay? And it's going to take all of us working together on changing what we see and improving the health of our residents here in Alameda County. It's not just us as the health department. Now, as a health department, we have one unique role, and it's a mandated role, and it's the most unique, and I don't know any other organization that is responsible, that it must do this, and that is measure the health status of the population and regularly report on it. Now, some of you may do this within your organizations, but we're responsible for that. We have to do that. And it's something that we take pride in doing, and one of those things that is in there as well that we have to do is we have to talk about the social factors that impact health. Most people don't know that. So when we step into another area that's not particularly public health, we're not overstepping our bounds, but it's what we're supposed to do. We're supposed to identify what's going on with health in other areas, the social factors. Now, working in partnership is something that we have tried to cultivate in this department. And so we're happy to have you guys see our update in terms of our 2008 life and death from unnatural causes report. Now, it was something that at the time, it took years for people to start talking about. It took years for us to present that data. We still get questions on that data, and it takes years for people to say, oh yes, I can see the link. And sometimes we have to be very explicit about that. Some of you can see the link readily. Some of you say, well, it takes a little bit more for me to explain it to a person that I'm trying to work with. But that's okay, but you're getting the image, you're getting the message that health is not just simply about an individual's choice. It is also about what surrounds them, what they have access to, and an opportunity to actually take part in. It's not simply the access. It's that opportunity to take part in, that it's easily and readily available for them. Now, in order to achieve the vision, it takes us looking at data to see whether or not we got there. But it also takes your experience in what you see, both as an individual and as a person working with others. And it's that experience and that data together that helps to identify what things do we need to do, what things do we need to do differently. So I don't want to discount data, but it's that experience in combination with data that helps us to figure out what we need to do. Now, the innovation can come in a bunch of different ways. For some things, I like to call it the 3 Ps. It can come in policy, specific policy or regulations. It can come in practice. Maybe not policy, but what you do, how you do it. And it also comes in partnership. Are we partnering with the folks that we need to help us on the things that we can't do? And that we is all of us. Whatever it is you're working on, whatever you need to accomplish, whatever you need to understand, are we partnering with the right folks? Now, that's 3 Ps, but there's another letter, and that's S, and it's that service that we provide to folks in whatever venue we're doing it in. Is that service having an impact? And if it's not, what's going on? Okay? The last thing we have to do is implement. Whatever we decide we want to do, we actually have to follow through on that and implement it. And then we get back to experience and data. It's a circle. Okay? So today we're going to show you our latest update in terms of this. And this report, again, is going to be an update of what we've seen from 2008. But when you see this, you may say, well, what do we do? We had a lot of recommendations on that. Well, fortunately, there'll be a part 2. Not today. But we'll give you the data, have you think about it, mull it over, think about what things you may think we need to do in order to change things, and then have you come back at another point to have a conversation about what it is you think should happen. Okay? It's one thing to show data, but it's another thing to take the data and then move to action. And so now I want to turn it over to Tammy to go through what we're going to see today in this presentation. Tammy Lee.
We are very pleased to see this size of group here to take a look at our data on how place, racism, and poverty matter so much for health in Alameda County. I want to be clear about what we're trying to accomplish today, and what we're trying to do is really walk you through our latest data on health and social inequities in Alameda County and our interpretations of the data, how we're talking about it. And that's so we can really increase your understanding of what factors need to be addressed to improve opportunities for health throughout our county, and also so you can take some of this data and use it, okay? Use it in your work to advance health equity. I'm sure some of you are writing grants where you have to establish need. Some of you are working out in the community to advocate for changes in certain aspects of the neighborhood. Others of you are doing actions, but you want to see whether they're working to help to improve health and social equity. Or maybe it's a dinner conversation piece where you're just trying to talk to someone who doesn't really get why place, racism, and neighborhood poverty matter for health in our county. So this BBU is an opportunity to walk through all of our latest data so that you have it at your fingertips and can go out there and put it to use. Okay, so we are going to delve into a lot of our local data, but to get us started, I would like to get a drum roll from everybody, however you can. Drum it up. Okay, so now we're ready to delve in. Many of you know our county is known for its innovative work in moving toward health equity, but we're not there yet. In Alameda County, the opportunity to live a long, healthy, and productive life is not evenly distributed throughout the county. Here you see a map of life expectancy by census tract, and it's clear that good health outcomes are concentrated in certain places, and ill health is concentrated in certain parts of our county, the dark red areas on the map. The poorest health outcomes, in this case the shortest life expectancies, are concentrated in parts of North, West, East Oakland, unincorporated Alameda County, and South Hayward. People living in these areas can expect to live in over 9 fewer years than people living in the light yellow areas on the map. How many of you live in Oakland? Okay, if we zoom into Oakland, you can see how just a few miles distance can greatly impact life chances. People living in the Northwest Hills can expect to live 1 decade or more longer than people living in West Oakland, Elmhurst, or Central East Oakland. And if we factor in racism, we see even more disparate differences in life chances depending on place and race. Compared to a white child born in the affluent Oakland Hills, an African American child born in West Oakland can expect to live 14 fewer years. So why is it that place matters so much for our health outcomes? Well, where you live determines your level of access to resources and opportunities that produce good health. Things like safe streets, good schools, quality jobs. And where you live can also influence your level of exposure to factors that harm health, like crime, air pollution, or inadequate public transportation. In this country, we know that we have an ongoing history of discriminatory policies and practices tied to race, ethnicity, and socioeconomic status that have produced this difference in access to resources and opportunities for health across neighborhoods. Health outcomes and life chances are greatly shaped by whether you have a chance to live in a community of opportunity or have to live in a disinvested neighborhood. So in this presentation, we're going to discuss some of the key factors that have led to racial and spatial differences in opportunities for health within our county, based on our local data. We'll focus on concentrated and persistent poverty, racial residential segregation, and inequitable, what we're calling economic, psychosocial, and built environment conditions across neighborhoods. It's worth noting that these factors are interrelated, and we simply have organized these different categories so we can take a look at the local data related to each. It's also important to recognize these factors all operate within and result from a broader system of structural racism within our country, where public policies are made, institutional practices are adopted, and cultural norms are enforced and reinforced in ways that perpetuate racial inequities. We know these health inequities and the root causes of these differences in health, they weren't created overnight. In the US, we have a long history of intentional public policies and private practices that have led to high concentrations of people of color and poverty in certain places. And here you see some of the examples of how racial residential segregation and persistent poverty have been historically legislated in direct and indirect ways. We'll talk more about racial redlining, but we'd like to ask if anybody in the audience has questions or would like to speak about one of the historical examples listed. I saw. Okay. Keep some of these historical events in the back of your mind throughout this presentation. We'll talk about racial redlining just for a little bit. Beginning in the 1930s, the Federal Homeowners Loan Corporation facilitated racial redlining, or denial of home loans in certain areas based on racial composition, by creating color-coded maps that used racial criteria to appraise how secure neighborhoods were for real estate investment. Racially homogeneous white neighborhoods were colored in green and deemed to be the least risky, while integrated neighborhoods, often majority black, were lined in red and deemed to be the least desirable for investment. Banks and insurers adopted Holck's maps to guide their lending and underwriting decisions, which influenced which communities got invested in. Here's a look at what racial redlining looked like in Alameda County in 1937. You might be able to see that large parts of North, West, and East Oakland and West Berkeley were redlined as being the riskiest places for investment. And these redlined places are places that suffer to this day from ongoing disinvestment, concentrated poverty, and unequal access to opportunities for health. So keep this historical background and in some of the structural contexts we talked about in the back of your minds. And we just touched upon those points. But keep them in the back of your mind as we go through our data on key determinants of health inequities in Alameda County. So first we'll take a look at our data related to concentrated and persistent poverty in certain places within our county. Let me begin by quickly clarifying how we're defining poverty. So according to 2013 federal poverty guidelines, a single person earning an annual household income of less than $11,490 and a family of 4 earning less than $23,550 are living in poverty. And neighborhood poverty is about the percentage of residents in an area who live in poverty. When 20% or more of residents live in poverty, the neighborhood is considered to be high poverty. And in this presentation, we further define neighborhoods with 30% or more in poverty as very high poverty neighborhoods, and those with less than 10% as affluent neighborhoods. Here you see a map showing neighborhood poverty levels by census tract in Alameda County. And you can see that poverty is not equally distributed throughout our county, and that neighborhoods with very high poverty, shown in dark red, are clustered in certain places, including parts of East, West, and North Oakland and Hayward. That pattern might sound familiar. It's very similar to that which we saw for life expectancy. And many of the highest poverty neighborhoods in the county suffer from the poorest health outcomes because of fewer health-enabling resources and more health risks in these places. And today we'll look at the data that's related to this. Beyond the level of poverty experienced in neighborhoods, we can look at how long conditions of poverty have lasted in neighborhoods, or persistence of poverty. We define persistent high poverty as neighborhoods that have been in high poverty for all of the past 5 decades, so from 1970 through 2010. And then we have frequent high poverty for neighborhoods that have been in high poverty for 3 to 4 decades, and so on, in how we're looking at persistence of poverty. And here you see the map showing persistence of high poverty by census tract. Parts of East, West, and North Oakland have experienced the most persistent levels of high poverty in the county. In the face of long-standing disinvestment, people living in these places often have especially few resources and weak infrastructure to support health. I'll pause here and just ask a big question, which is whether we have some ideas of what we can do to improve conditions of concentrated and persistent poverty.
Redistribution of wealth.
Redistribution of wealth is a big idea that helps, gets at that.
Jobs.
Jobs.
And, yeah.
Shifting investment in the community. And I'll just say that as the health department, one of the things we did, Dr. Davis recently wrote an op-ed in the Oakland Tribune urging that we have to preserve our social safety net programs in the face of increasing numbers of people living in poverty. We know budgets are stretched and there's cuts that are going to have to happen, but we say we need our social safety net programs preserved, and we need to promote investment in the community, public and private investment in the communities that have been disinvested. Together with grassroots community and financial sector partners, our Place Matters economics work group, they're currently working to advance policies that enable local government to leverage its resources and ensure that taxpayer dollars are invested in institutions that expand access to non-predatory financial products, small business loans, and other financial services in underserved neighborhoods within the county. There's more information. I don't know if we had enough out there for everyone, but there's more information on that effort at the tables. Yes.
It's been shown that a large factor of generational accrual of wealth has to do with owning property. And there's been some recent suggestions that a lot of the recently foreclosed housing is not being made available for resale to people in the community, but it's being sold in blocks to investors that are then sitting on it and waiting for the property rates to go up. There's some really innovative ideas that have come out of Detroit where the city has actually started a nonprofit to have people invest in the city value. There's something called a popsicle index that means how safe is it for your child to walk to the store and get a popsicle. And that people in the city who have been investing have been able to buy up that property, the actual city has been able to buy it up and make sure that people who are residents in the area have access to rebuying it in an effort to raise the value of property, which then I could probably find the NPR story for you if I wanted, but that's the best I can do.
And this is in what area?
Detroit.
This is in Detroit. There are efforts underway locally to try to ensure that local residents have access to these foreclosed homes. Is anyone here to speak to that? Okay. So in our county, neighborhood poverty and health outcomes are closely related. What we see is a social gradient in health, and this means with each step up in neighborhood poverty, we see a decline in life expectancy. And in this presentation, we'll talk about some of the disease and neighborhood conditions that seem to be behind this life expectancy gap. Ooh, okay. So anybody outside of the Cape unit know what the leading causes of death are in Alameda County? You can just popcorn them out.
Homicide.
Heart disease.
Stroke.
Cancer.
Overdose or drugs.
Respiratory
Cancer.
HIV/AIDS.
So most of that is right. Number one is cancer, then heart disease, then stroke, chronic lower respiratory diseases, including asthma, unintentional injuries. Those are our top 5 leading causes of death in the county. And you can see from this image that these 5 conditions account for 62% of deaths countywide. The top 4 conditions are chronic diseases, and all 5 conditions are major causes of death that can be prevented by doing things like improving neighborhood conditions, reducing risk of disease and injury, and expanding access to timely and appropriate health care. These are preventable conditions. We can do something about it.
Are there any studies done about environmental contributors to the cancer rate?
I'm sure there are many.
I mean specifically in Alameda County.
Specifically in Alameda County, the data that I'm aware of around lifetime cancer risk, that off the top of my head, and you'll see in this presentation is included, is in West Oakland, and it looks at how the concentration of highways and the location of the Port of Oakland and all the sources of air pollution really affect things like respiratory health as well as lifetime risk of cancer in that community. I'm sure there are other examples of research being done around that.
So are the top 5 leading causes of death the same across different population groups?
So that's what we'll talk about here. Thank you. So different population groups in terms of neighborhood poverty levels. So people tend to die most frequently from these 5 conditions across the board. There's just 2 exceptions worth noting. In affluent neighborhoods where people live longer, Alzheimer's disease comes to the top. And then in very high poverty neighborhoods, homicides emerge near the top. So some of you called out homicide. It is a leading cause of death in our very high poverty neighborhoods, not in the top 5 in the overall county. Here you can see that rates of death from the 5 leading causes of death rise with increasing levels of neighborhood poverty. There are also higher levels of morbidity or disease burden in neighborhoods with higher poverty. The rates of visits to the emergency department for diabetes, asthma, obesity, and assault are about 2 to 4 times higher in high poverty neighborhoods compared to affluent neighborhoods. And neighborhood poverty, it seems to impact health over the entire life course. Here you can see how all-cause mortality rate is higher in very high poverty neighborhoods compared to affluent neighborhoods across all age groups in our county. And of particular note is the real effect that neighborhood poverty is having on premature death before age 65. So school-age kids and teens living in very high poverty neighborhoods are dying at almost 3 times higher rates than their peers in affluent neighborhoods. So the impact is happening early. What's going on? What's causing death among our young people? Well, here you'll see the main conditions that are contributing to premature death in very high poverty neighborhoods. And among youth, homicide and unintentional injuries account for 81% of the deaths. And that's such a bulk of the problem. I was interested if we have any examples of work that people are doing to reduce risk of homicide or unintentional injuries among young people in our county. Does anyone have an innovative approach they're trying?
I know Uprising did a gun buyback in West Oakland with the neighborhood police offering funds to buy back guns and get guns off the street without asking questions.
Can you speak up? It's hard to hear in the back.
I'm sorry. Youth Uprising did a gun buyback where they, brought folk in, worked with the police to get guns off the street, or at least to try to. That was one effort.
I work at Youth Uprising, and we also do youth employment development and support. So we subsidize jobs for young people in order to shift, I guess, contributors to violence in the community, which has a lot to do with income.
Great. So work to change economic conditions, work to get guns off the streets, and is there another example? Yes, please.
What are you listing for unintentional injuries?
That's a good question. Yeah, so unintentional injuries.
What was the question?
Oh, the question is what are we including in, or what does unintentional injuries mean? And the bulk of unintentional injury deaths are due to motor vehicle crashes, falls, and what someone said before about accidental poisonings.
My question is, she mentioned the buyback on guns. They've been doing that all around the Bay Area. Has that truly impacted the various neighborhoods, or they bought the old guns and they bought the machine guns? What is really going on in the
Anybody know what's really going on? Why don't you repeat your comment? Yeah.
The question is, all around the Bay Area, they are using that whole concept of buying back guns in the communities. My question is, are they purchasing their own old guns and the people are buying new machine guns? What is the actual impact of the buyback from the various communities? Does anyone know?
know the actual impact for every location, but I know we did a gun buyback program that was sponsored with then Senator Nonpredatory came to our church and did a gun buyback. And we found that the majority of the people who brought the guns were not the youth off the street. They were coming in, our church is in West Oakland, and they were coming from Walnut Creek, all these different affluent areas, bringing their grandparents' revolvers, you know, to buy back. But the actual youth in the neighborhood were not coming in and giving their guns. That's just anecdotal.
My experience at Youth Uprising and Gun Buyback, number one, our gun buyback is overwhelmingly more, I guess, substantial in terms of numbers that we collected. It was over 800 guns in the several day effort that we had. I know that there were a mix of guns, old and new guns. I'm not sure about the makeup of age ranges that turned in guns, but I think one thing to think about, especially in the times that we're in now, is about the danger that comes with home invasions and robberies and things of that nature, where guns can unintentionally be found in the streets and be used for different kinds of criminal activity. So I think that the gun buyback program is impactful in certain ways.
One thing I would say is that when we think about the number of different things that we can do to try to impact something, there's never going to be just one strategy. It's going to be a layer, a fabric of multiple strategies that get at different things.
I think many of our community partners, like Youth Uprising, East Oakland Boxing, the OUSD after-school programs, Lincoln, you worked at a program in Berkeley, throughout the county that are giving kids places to go after school in the summer, giving them tools for employment, a safe place to be, having fun so they can be kids, and getting to know other kids in their community, that can make a difference.
Under unintentional injuries, I was wondering if you considered looking at drug overdoses as part of that? And if you did, if you have data, a data source for it.
We do, and if you're interested, you can let us know.
Okay.
Let me know
Yeah,
after.
okay. I think we could
Yes,
get
we
there.
do have local data around that.
I think it'd be good.
I've been trying to find the name of the organization, but it's two psychologists, one of which was has worked in some public service agencies here, but they created a trauma-informed care practice with grandmothers of folks in East Oakland that are taking care of the grandchildren of people who have either been lost to the violence or incarcerated. And it was about a 6-week-long course where they looked at historical trauma, the trauma that's been inherited, and offered these people mindfulness tools to deal with their trauma and teach them how to navigate through some of the triggers and institutionalized oppressors that are causing them to stay. And I think the outcomes have been quite, they've been doing some follow-up studies at 6 months and a year with the folks in terms of what's happening with the children that they're raising and the outcome on them. And I think it's looking pretty amazing. I wish I could remember the name of the organization. Cheryl is the woman's name.
Okay. Speaking up front, please remember, sometimes people in the back can't hear, so project your voices.
So, I mean, I think Montu's point is, Dr. Davis's point about, you know, it's going to take many different strategies to get at this problem of homicide and unintentional injuries that's taken, you know, accounting for 81% of deaths among our young people. And it's going to take some different approaches, from doing gun buybacks, youth-led gun buybacks, and seeing if it actually has an impact, to increasing opportunities for employment, to dealing with historical and ongoing trauma faced in these communities. It's going to take a number of different strategies that I hope we will all continue to advance to get at this problem that is leading so much to premature death among our young people.
Yeah, I happen to live in one of those communities. I think it's true, as Montu was saying, I think it's going to take a collective effort. But actually, on my way over here, there was a roadblock, you know. So whatever we're doing, we're not doing enough. I'm not saying to people in this room, but I think there's a lot of political issues here. And I think that it's unfortunate that a lot of the same people that seems to do the violence over and over again. It doesn't seem to be a lot of people. It's just so. But yeah, it was just unfortunate because on my way over here, I'm assuming there was another shooting in West by the BART station, and I just think that something obviously needs to. I'm glad. I think this is a great. I commend you for really, bringing this sort of leadership to this situation, and I think we're on the right path.
Thank you for that. Conditions of concentrated and persistent poverty in urban communities of color have been powerfully shaped by racism and racial residential segregation. Racial residential segregation impacts where certain racial groups can live and in what quality environment. So it powerfully determines health outcomes. And here we'll take a closer look at what racial residential segregation looks like in our county. So what you'll see here is, bear with me, the racial ethnic distribution of our county overall and for each neighborhood poverty level. So there's the racial distribution of our county, and there's what the composition looks like by neighborhood poverty level. And so green is white, Asian is orange, Latino Hispanic is red, blacks are blue, and then all other races are at the top. And so what you can see here is that our affluent neighborhoods are largely and disproportionately comprised of whites and Asians, and that our high poverty neighborhoods are largely and disproportionately comprised of Latinos and blacks. 91%, you can see 91% of our residents in very high poverty neighborhoods are people of color. And I'll just reiterate here that historical policies and practices like redlining and ongoing structural racism, they've really shaped these racial patterns that we see.
I wanted to know, do you break down the Asian groups so that we can see the subgroups? Because there's a lot of Asian communities that also live in very high poverty levels.
Thank you for that. That is a really good point, and I believe our Pacific Islander numbers, I think that in terms of those are just, I believe these are just represent our Asians, and our Pacific Islanders are represented in the all other races. Numbers limitations, but you're right that there is extreme economic diversity within each of these racial ethnic groups. Yes.
So where we can get to that granularity, we do. But as Tammy's mentioned, sometimes the numbers just aren't sufficient to say it's inaccurate count of that. But where we can, we do.
Thank you.
So if we cut this data a little bit differently and look at where people of different racial ethnic groups live by neighborhood poverty, we see that 1 in 15 white residents live in high poverty neighborhoods compared to 1 in 9 Asians, 1 in 4 Latinos, and 1 in 3 blacks. So the odds of living in high poverty neighborhoods are much higher for Latinos and blacks. And so the question kind of arises then, are these racial patterns due to differences in access to income? Well, we can look at where poor people of different racial ethnic groups live by neighborhood poverty level, all of whom have low access to income. And we still see differences in the odds of living in affluent versus high poverty neighborhoods, with poor whites being much more likely to live in affluent neighborhoods compared to poor blacks and Latinos. So beyond how much money you make, racism is at work in shaping unequal opportunities to live in neighborhoods with resources and amenities that produce good health. With greater access to opportunities for wealth and health, whites have consistently enjoyed better health outcomes compared to blacks in Alameda County. Here you see the life expectancy for whites versus blacks from 1960 through 2010. And you can see that for both groups, health has been improving over time, but that the gap between the two groups has grown. And so I wanted to ask, what are your thoughts on what kind of things are contributing to this rise, widening of the gap in health? Distribution of wealth, access to health care, stress,
Quality of public education.
quality of public education, what you have in your neighborhoods.
The care you receive once you're in the hospital, if you have conditions.
So not just access to care, but once you're in the hospital, what kind of quality care are you getting?
Rising health costs.
Rising health costs.
Criminal justice policies that lead to people's initial incarceration, binding them to things like gang affiliations, but then deny them access to support services while they're incarcerated.
Very good point.
Mass incarceration, and then its ongoing impacts on economic and employment opportunities afterwards.
Generational impacts of racism and poverty across generations.
Big one. Cumulative intergenerational impacts of racism and poverty.
Have supermarkets and other businesses like that rolling out in some neighborhoods, divesting with access to healthy food.
Supermarkets leaving the area, businesses, economic capital, and access to healthy foods then becoming a challenge.
High school graduation.
High school graduation, and as was set up here, the quality of the kinds of schools that people in certain neighborhoods are having to go to.
What about the number of liquor stores?
Number of liquor stores, we'll get to a lot of this. Oh, the grocery stores that some of these neighborhoods.
Not being able to get A1 vegetables and health foods that are better for your body.
Yeah, so even if you have access to foods in your neighborhood, there's not always the most healthy or affordable options for the people who need it.
I wanted to underscore Freddie's comment about stress, that long-term exposure to complex trauma from a lot of different sources, from historical trauma and immigration trauma, to community violence, domestic violence, creates pressures on people's emotional geography, and it can increase mental health issues, mental illness, and it impacts all kinds of other kinds of physical health.
Which goes back, we need to revisit what they're doing.
And that's where the Trauma-Informed Care Innovations Project was funded through behavioral health care. But the deal is that trauma impacts health in a very systemic way, and that the departments don't necessarily promote trauma-informed care approaches, which actually are easy to learn and not expensive.
Okay, so I think we all need to learn some more about this trauma-informed innovative project.
Can you say the name of that project again that was funded by behavioral health?
Actually, can I just say that behavioral healthcare has a trauma-informed initiative and a trauma-informed website, and the name of the project is, which is one small part of a larger strategy that sits in behavioral healthcare. The name of the project was, does anybody know? But Tracy, do you know? Do you remember?
The website is called Alameda County TraumaInformedCare.org, and so on that website you can find more information about the initiative, and there's information on there for individuals who have experienced trauma, as well as for providers who are interested in learning more about trauma.
Thanks.
Sorry, this is a pretty loaded piece of information I'm going to give you, but bear with me, okay? So race is a social rather than a biological construct, and we know that when we see differences in health outcomes by race, it's not something biological we're measuring. It's a measure of how racism is functioning in society. Here's one illustrative piece of data that we have. If we look at low birth weight outcomes by race and place of birth in Alameda County, Blacks and to some extent Latinos and Asians fare better if they were born in a foreign country compared to if they were born in the US. So this suggests beyond biology, something innate to certain racial groups, there's something about being born in the US and experiences of racism, oppression in this country that increase risk of low birth weight among certain racial ethnic groups, and Blacks in particular. Better low birth weight outcomes among the foreign born. It could be partly explained by immigration of the fittest, to this country, but it's notable that you see the reverse pattern for whites, where whites in the US are doing better, whites in Alameda County. And then you also see that the low birth weights are especially high. There's especially a gap among African Americans and blacks. And now we'll take a look at how the quality of neighborhood conditions vary depending on where you live. And we'll begin by looking at economic conditions like employment and wealth. There is greater access to employment if you live in affluent neighborhoods within our county. The unemployment rate is 2.1 times higher in very high poverty neighborhoods compared to affluent neighborhoods. And this could reflect limited job availability, transportation barriers, or lack of quality education and training opportunities in these areas. There are also differences in job quality. Here, what you'll see is the top 5 occupations by neighborhood poverty level. So in our affluent neighborhoods, 52% of the working population over age 13 is working in these 5 occupation areas. And you can see the median income earned by workers in each of those occupations. And then if you look in very high poverty neighborhoods, 49%, almost half of the population is employed in each of these 5 occupational areas. And you can see the median earnings shown there. Yes. So in affluent areas, it's management, office and admin support, sales and related jobs, computer and math, and business and financial. And in very high poverty neighborhoods, it's office and admin support, food preparation and serving, construction and extraction, sales and related jobs, and building and maintenance. And for those of you who can't see, in general, the median income levels are much higher in the main occupation areas within affluent neighborhoods. And if you look within occupations, so if you compare what someone working in office and admin support gets, who lives in an affluent neighborhood versus a very high poverty neighborhood, within the same job category, you're making more if you do the same type of job and you live in a different neighborhood. So in our county, a single adult must earn $27,456 per year to cover basic living expenses. And while the top 5 occupations in affluent areas tend to earn above this basic standard, the top 5 occupations in very high poverty neighborhoods earn around or below what's required to make ends meet. And so access to employment that pays adequate living wages for people to be able to make ends meet is something that we need to work toward. There is a 2.4-fold difference in annual household income of residents of affluent versus high poverty neighborhoods. Most of us know fewer income resources means you have a greater likelihood of having to make trade-offs that matter for health, like paying for food or housing or your health care. And that at the community level, lower income earnings means a smaller tax base and greater risk of political disinvestment, both of which harm community health. I'm hoping that we might have some examples of work that's being done to increase access to income or employment in high poverty neighborhoods. Yes.
The Project EAT program, which is with the Office of Education, is now modeling a urban farming project with young people, and they are paying them a living wage, and they're able to take classes, financial support classes, as well as farming classes. And they're working in the Ashland, Cherryland area, as well as Hayward.
And what's the name of that?
Project EAT, and it's with the Alameda County Office of Education.
Project EAT?
Yes.
And she's talking about urban farming as an opportunity to link youth to employment, as well as provide a more sustainable source of income.
It also works
Do we have one more example? I'm hoping we're doing more than this. I did share how our health department is trying to leverage our resources to be able to, at the local level, ensure that we have better access to non-predatory financial products in the communities that are disinvested in. So ensuring access to non-predatory financial products is one strategy we're working on.
I think the noteworthy strategy the health department's worked on is the EMT training of at-risk youth, because those are much higher paying jobs than most of the jobs that we saw there.
EMS Corps is a program that Alameda County is piloting and now expanding, and it's getting a lot of at-risk, particularly young men of color, engaged in jobs that pay good wages.
Behavioral Healthcare Services has Alameda County Vocational Program, which has recently switched its strategy from asking the 4,000, let's say, adults that have most severe mental illnesses to go to this vocational program to get help, to decentralizing it to putting job developers in the service teams where these folks receive services from case managers. So that's a strategy we're using. It is a systemic change. It's more about trying to make a match between people that have severe mental health issues and helping them to get back into the workforce with job coaches and job developers.
That's great. And we'll show some of our data around what's going on in terms of the severely mental ill in a little bit. Yes, one more comment, please.
At the same firm at Living, we're working with actually a group that you haven't touched on, which is people with disabilities, who cut across all racial, ethnic, socioeconomic categories, and who are the poorest of the poor, the most unemployed or underemployed anywhere in this country. And so we're working with people who have been turned away from the one-stop centers and don't have access to traditional employment programs, and working with people to get job ready, but also addressing the poverty track of SSI and SSDI and the entitlement programs that keep people in poverty.
Thank you for offering that. For those of you who couldn't hear, she's talking about some of the strategies they're taking to improve access to employment and more sustainable income among a group that is often doesn't have interventions targeted toward it, so people with disabilities.
I have 2 examples. Inner City Services, located on Shattuck and Adeline in Berkeley, does a program where folks who are living in poverty or homeless in Alameda County have access to computer training in the Word of Microsoft, and they get a certificate that allows them to enhance their resume building. Also, St. Vincent de Paul has a program where they're partnering with BOSS and other agencies to do culinary track through their Kitchen of Champions, where people are able to come in and get subsidized work training and then leave with a culinary certificate. So those are 2 examples. And also the Workforce Collaborative down on 14th and between Franklin and is doing a program where they have folks that are eligible to participate in forklift operator training. So there's a lot of reaching out to industry and trying to develop subsidized training programs that are available to people so that they can be employed at a higher level.
Thank you for all these ideas of good work being done out there to help us to address the challenge of unequal economic conditions. I'm gonna jump to looking at some of our inequitable psychosocial conditions. So this involves social conditions like education and violence, and then also psychological factors like stress and mental health. Residents of very high poverty neighborhoods are almost 4 times more likely to have less than a high school degree than residents of affluent neighborhoods, which really reflects varying levels of resources and opportunities to achieve school success and opportunities for higher education across neighborhoods. There are large differences in academic performance between affluent and high poverty neighborhoods. Here you see an over 2-fold difference in 3rd grade reading proficiency levels, which is an early predictor of high school graduation rates. Children in high poverty neighborhoods face many barriers to academic success, ranging from schools with too few resources to address student needs, to greater exposure to air pollution, to lack of access to health care, to manage chronic health problems.
Question about this slide really quick.
Yes.
Are you looking at by school or by student in that?
We're looking at it by where students are living.
Where students live, but that's not necessarily the school they go to?
Yeah, so this is based on, students don't necessarily go to their neighborhood schools. So yeah, this is looking at what does it look like based on where students are living. Because we're short on time, I'm going to move through these different pieces a little bit quicker, and I just want you to get a broad survey of kind of what are these unequal neighborhood conditions we're talking about. So within Oakland Unified School District, 1 out of 6 students living in high poverty neighborhoods are absent from school for 10% or more of the school year. If you're absent at that kind of level, it's hard to achieve in the same way as students who are there every day. There are efforts that are underway to try to reduce chronic absenteeism. I'm not going to go into the details, but our Place Matters education work group, we're trying to pilot an effort in the Hayward Unified School District to help to better coordinate supports and services to students and address health-related absences. You can see here neighborhood poverty clearly impacts levels of crime and violence. And in our county and in much of the nation, low-income neighborhoods and communities of color bear a disproportionate burden of mass incarceration. So I just want to talk through this data because it's important. Here you see that 1 in 40 youth in very high poverty neighborhoods is incarcerated for overwhelmingly nonviolent offenses, compared to 1 in 200 youth in affluent neighborhoods. This is an over 5-fold difference in youth incarceration rates. This inequity, it's largely due to complex factors like institutional racism, inequitable education systems, limited economic opportunity, but it's not a consequence of individual behavior. And we know the many ways in which incarceration directly and indirectly affects people's health, including what someone else mentioned, which is once you get out of being incarcerated, what kind of economic and education opportunities do you have access to, and what kind of barriers do you face? People in high poverty neighborhoods often face multiple stressors. We've talked a lot about some of the different ways in which they experience challenges, but the constant pressure and lack of control, it triggers a chronic stress response, which over time actually wears down body systems and increases risk of ill health conditions like hypertension or diabetes. Here you can see that the rate of hospitalization for hypertension is almost 2 times higher in high poverty neighborhoods than in affluent ones. Experiences of racism at multiple levels, including institutional, interpersonal, internalized racism, it can serve as a chronic stressor that contributes to increased risk of hypertension among blacks in particular. So here you can see across neighborhood poverty levels, blacks have the highest rates of hospitalization for hypertension. And the reasons for greater hypertension risk, we need to continue to better understand those. But it seems that racism and associated chronic stress are likely contributing factors. Chronic stress increases risk of depression, anxiety, and other mental health disorders. And severe mental illness, it substantially impairs people's ability to carry out major life activities. And here you can see that you're looking at almost 3 times higher rates of severe mental illness in high poverty neighborhoods. Yes.
Does that data include ED visits from all hospitals, public and private, across the county? Yes, right? Is that right?
It's zip code of residence.
Zip code is resident. So it's
Wherever they go in the state,
Okay, the last determinant of health that we'll examine are unequal conditions in the built environment. And I'll just move through, I'll touch on these, but I'd really like to leave just a little bit more time for discussion at the end. So here's one indicator of housing quality and potential health hazards, age of the homes. And you can see that almost half of the homes in high poverty neighborhoods were built before 1950, compared to 1/5 of homes in affluent neighborhoods. And I'll just highlight that in our work with community partners, we've seen a particular problem of substandard housing conditions, especially mold and moisture, among tenants. And our current approach is to try to improve code enforcement's response to these issues. So there's more focused and preventative response to tenants with children at health risk from housing conditions. Higher levels of household overcrowding, often a reflection of lack of affordable housing options. And in terms of housing affordability, you can see there's almost 2 times higher rates of severe housing cost burden among renters in high poverty neighborhoods. And the percentage of households without a vehicle is 7 times higher. And what this means is that in our high poverty neighborhoods, there's a large number of residents who depend on public transportation, affordable, reliable public transportation to get to places that they need in order to be healthy. And it's particularly important in those communities, the transit-dependent communities, that they have access to affordable, reliable transportation. There are executive summary copies, or you can check it out online. This is a report that we did in 2013 to help to get at what are the health impacts of bus funding and access. Safer streets in affluent neighborhoods compared to very high poverty neighborhoods. More limited supermarket access. And someone mentioned about liquor stores. Liquor stores have a potential to directly and indirectly harm health by influencing levels of alcohol use, crime, violence, and drug activity in neighborhoods. Here, what you see is the density of off-sale liquor outlets. So that's places where people can buy alcohol for off-site consumption. And you can see that the density of off-sale liquor outlets is almost 2 times higher in very high poverty neighborhoods than in affluent ones. We talked about, I mentioned a little bit about how air pollution sources like factories, freeways, and goods movement corridors, they tend to be located in or near high poverty neighborhoods. And here you see in West Oakland how much that community is surrounded by highways and how close they are, how they're living in the shadow of the Port of Oakland, and it's reflecting in their asthma and their lifetime cancer risk. It also seems that low-income neighborhoods and communities of color, they tend to be burdened by a disproportionate number of hazardous facilities that can pollute the groundwater and the soil with toxic contaminants. So in Alameda County, the density of industrial, chemical, and fuel release sites in very high poverty neighborhoods is 4 times higher than in affluent neighborhoods. Go into Okay. Okay, so we'll conclude by looking at some of the complex ways in which place, racism, and neighborhood poverty, how they interact in Alameda County. And so I just want to highlight here that we know from this dotted total line that neighborhood poverty matters greatly for differences in life expectancy in the county. And you see this pattern among blacks and among whites. And the impacts of racism on blacks are particularly apparent since within each neighborhood poverty level, blacks have the poorest health outcomes, in spite of what should be similar access to neighborhood resources. But if we look among Latinos and Asians, a different pattern is observed. Both groups seem to have resilience factors that bolster their health in the face of high poverty neighborhood conditions. Do we have ideas in the group about what are these resilience factors that might be enhancing health among Latinos and Asians?
One of the things I culture with them. African Americans have never been able to bring their African experience and cultures with them because of slavery. So therefore, not having that background has really a big impact, and I think this really shows it. A lot of times when white Americans come to America, they cut off the culture in the old country because they have so many great opportunities in the new country. And therefore, they let loose of the ties in the old country. But again, the Asian and Latinos hold on to the culture.
So cultural protective factors and being able to retain your culture.
And religion.
And spirituality.
And just to take a piece of what Freddie said and expand it, it's to the African Americans have been living here enduring complex trauma for generations and generations and generations. And the Latino immigrants and the Asian immigrants have been here for a couple of generations. And so it impacts their health because they have more resilience, because like Freddie said, they bring their familial relations which have not broken down, and their spirituality and local healing from the other countries. And also it's only a couple of generations of living in toxic environments, the toxic physical environment. And so it's a matter of generations versus a decade or so. And that impacts health. And resilience is what we're talking about.
And the schools, when they're teaching African American history, they're just skimming over it. They're not really going in depth to it. They're not,
and I don't, and I also believe that the young people today, their parents are not talking about, they're not doing oral history. They're not talking about what happened to their grandparents. And because my parents talked about what happened, but my parents were born in the 20s in Louisiana. So they talked about what went on when they were growing up and how things are different and how things have changed. But I don't think that the folks raising children today are talking to their kids about what it used to be like and where we came from. And when you don't get that oral history in the home, then you don't know. We have roots, but it has to come from the parents. The parents have to bring it down. The grandparents have to bring it down, and I don't know why. Maybe they're too busy. Maybe they're embarrassed to talk about it, because it is difficult to talk about, that when this person in Louisiana talked about that blacks and whites should have the same salary, the teachers should have the same salary, that he was found in a ditch with his head partially cut off. That's real difficult to talk about, but that did happen. It doesn't happen today, but in the 50s, that happened. So I think that's a big part of what's going on in the African American community, and we need to try to get over being shy about talking about things like that, especially when we have children who are getting older and who can, you don't want to tell that to a 5-year-old, but you should be able to tell that to a 15-year-old.
I think it's important that, just like the young lady was saying in the back, a lot of times we have not shared with our younger generations, our children, the trauma experiences that our foreparents went through to get to where we are now. For me to go to college, what my parents had to go to, my father had to go to the military, and yet at the same time, that's how he escaped the South. But again, for many others, many of them had to leave the South because out of necessity. It was just no other choice. So therefore, there's been choices made. And a lot of times we have not been able to communicate that to our young in a way where it's done with honor, and at the same time for them not to feel bad about our experiences, because that's our experiences. That's what happened to us as a people. And I think we got to start looking at how we better own that as a people.
Can I add that I feel like African history is world history, but it's glossed over. There's also, I feel like a disparity or a disproportion when it comes to positive African history versus just a single 400 or 500 year time span. And so I think that in general, that kind of speaks to the curriculum and the information that's being presented to young people in general. So I think that has ties to identity, as well as thoughts about what kinds of opportunities or things that we can achieve in general. So I think that goes a very long way when it comes to information being exposed to our young people.
Thank you for that. In the back?
I think also around food, I think recent immigrant communities are still carrying over practices that they may have had
back home, and so looking at communities that grow their own food versus being dependent upon subpar grocery stores in the neighborhood. And so I think there's something you said about community gardens and the type of food that's being cooked in the household that has long-term impacts on young people's health. And I think that that's something that is very present in the Black community, is eating food that is in our neighborhoods that's not necessarily good for us versus, I think, probably in other communities, cooking more food at home, cooking food that is still made with a lot of vegetables, and that's a part of that culture. So I think that's maybe a factor.
So yeah, some of it is that how young people are being educated in schools. Some of it is about practices in terms of our eating and retaining our healthier cultural practices in the home. And then we'll take one more comment.
I think that part of the issue is that not that there are stories that parents don't tell or don't have that they want to tell. It's the fact of not being, they would like to tell those stories, but if you're a mother of an African American son, you aren't worried about telling them a story. You worry about them getting home safe. We live in so much fear for our child. It's not like they can go out, because we have a saying here, but maybe not, I won't say here. 2 of us together is a group, 3 of us is a gang, 4 of us is a mob, 5 of us is a riot. This is when you work someplace. They see 2 blacks together, people get all anxious and excited. So you can imagine if 5 young men, black young men, walking home someplace, do you think that mother is worried about a slave story to tell them? She's at the window looking for her child, because she doesn't have to worry about them being stopped by the police is one issue. Being said that you don't look like the people that live in that neighborhood you're walking through. If you're in a car, the police may stop you, or somebody may just want to drive by and shoot you. So we have so much fear and trauma that we live with every day to get our kids to school, out of school, to a college. So they worry why we have hypertension, you worry why we have stress, you worry why we don't have stories to tell. We're too scared to tell them, because they're all about fear. And just to be able to see your kid walk through the door, that's made me cry some nights when my son was a teenager in one of the better neighborhoods, just because what he did with his friends is verging on them doing something that can get them arrested, while the same group of white boys 2 blocks over doing the same thing, just boys being boys, just kids being kids. That's what gets a young black man a juvenile record and gets a white boy a pat on his back as a rites of passage. So let's be honest about all the things that keep our kids and their parents from saying we can do better. Do we teach our kids we can do better, can go further? Sure we do. But it's always with that in the back of my mind, God, please protect my child today. And it's at the schools in the daytime and the streets at night. And sometimes within the school walls during a school day. So we got a lot of stuff going on.
After they get older. So
Right.
it doesn't stop just
Right.
because they're in the school.
Exactly.
Even when they're in their 20s.
That's right. And you marrying them off and hand it off over to their spouse. It's like, but you still worried about the family then. So anyway, it's just a lot of those things. And when you talked about one thing about the housing, you talked about the houses built in the 1950s. Open up any neighborhood paper to the real estate section on Sunday, and you'll see the gentrification going on. People rushing to buy those 1950 houses with the beautiful wood and all of those things going with it, that some families being pushed out of, that lived in mold for years, but nobody cared about it.
Last comment over here.
I want to say 2 things. One is on this topic. I think it's a serious misrepresentation to say black people did not bring their culture. It's a much more complicated than that. We bring our culture everywhere, and we went just like any other group does. What needs to be looked at is, in the case of health, is why is it that black businesses, black restaurants have not been able to develop to the degree that other restaurants, other businesses that have, which might service their own community. That has to do with politics, economics, and the racism within that. And the black community as a direct product of that in terms of their health thing. The other piece I want to say on that is, which would be useful for a study, one drastic difference, which I see every day in East Oakland, where I live downtown, is fast food. I would think that this department could do a study between Asian, Latinos, African Americans, and whites who uses fast food. And all of fast food places I go to, 90 to 95% of the people in it are African Americans, precisely because they don't have black restaurants to go to, or other places, or places where they can get healthy food items like farmers markets and so on. One could look at who comes to the farmers markets, even in West Oakland, and that there are less percentage of black folks going to those markets where you could buy healthy foods right at the street from the vendor than that happens for other groups. And so we don't have taco trucks, which actually have relatively good healthy food, and as well as tasty food and cheap. But so we go to Burger Kings, we go to Pizza Huts, and any fast food, and the quality of food is much lower there, and that is not an accident. Last thing I want to say, which is not about this, is last night on TV there was a program called The Waiting Room about Highland Hospital, and they'll show it again on probably one of the PBS stations. But it's really worth seeing because what it shows is, what I got out of it is the left. I mean, Highland is right over on 13th Avenue in near East Oakland, and all the people wait till the last minute. They have no preventative health procedures that they can go to, don't have regular doctors, they can't afford to go, and most importantly, psychologically, they feel they don't have the money of things they have to do to survive, that health is only there when they need it or when they're actually sick or right outside of the death's door. One little last thing, there was a kid on there was a white woman in this thing last night who's from Alameda who lost her job, and she came over to Highland. And what she said was, when she had a job in Alameda, she really hated the idea of Obamacare. Now that she doesn't have a job now, she actually is on Obamacare and thinks it's the greatest thing ever.
So we will be having a part 2 BBU where we hope to get into more discussion about what we're doing and what we can collectively be doing to address fear and trauma and access to healthy foods and all of these unequal neighborhood conditions. And Montu will just close it out.
One second. So the beautiful thing about communities is that you're all right. And the beautiful thing about community is that it takes all of us to shape it and change it. Now, individuals in general, when we look at what changes, how people make changes, it's often not individual. It's often within group. And so the point of that is that it takes all of us to shape what we see, how we talk about, and what we do. And it takes all of us to change what we see. Now, it's important. Now, I'm sure there's a number of emotions in the room. Some of it painful. Some of it joyous, because you understand something. Some of it, what the hell are we going to do? Take that, what the hell are we going to do, and think about it. At this point within our health department, we are moving towards creating a community health improvement plan based on priorities. As you can see, there's a lot to do. But unfortunately, we can't always focus in on every single thing. Doesn't mean that we don't work on it. But having a tremendous concentrated focus, even as an individual, as a department, as a group, we have to have some priorities. You see this framework up here, which means that there are various levels that we work on things, all of us. And it starts with our beliefs and our values. What do we believe in? What do we value? Where do we focus? Where do we practice? How do we practice? What ultimately comes of that in relationship to what the community sees, which often shapes what individuals see, do, hear, and feel. Now, there's more discussion on this. There's more to talk about. Hold what you have, hold what you feel, and bring it to our next discussion. Thank you.
One question. When can we get access to the full report?
So this full presentation, we are going to make available, and
Okay, but when?
As soon as I can see your email. If you left your email and check mark that you're interested, then I will send you,
Why
yeah.
don't you post it on your website? That way.
We will also post it on our website as well as a video of this BBU. And then I'll just say on the way out in the lobby, we have a display. If you have any thoughts you didn't get to share, please reflect them there.